Okay, good morning, good afternoon, good evening, everyone, and welcome to our LabCoP Extended Eco Session today. My name is Francis Ochen, your moderator for today's session. We'll take two presentations in this session and get to the questions and answers. We kindly ask you to join us through the chat for comments, questions, or alternative ideas related to the topic of discussion today. We do have interpretation services. Kindly keep to either English, French, or Portuguese, depending on your preferred language. During our last session, I actually indicated that you will be getting your CPD points accredited, and that is still holding. We will be sending this your way as soon as they become available. Again, just to note that you will still need to get your license numbers or registration numbers for us going forward to be able to link your accredited CPD points to you as an individual. Today's session is really looking at sharing implementation experiences from some of the early adopters of the WHO standard on universal access to rapid tuberculosis diagnosis. We know that sometime last year, we convened a session following the release of the standard on universal access to rapid tuberculosis diagnostics. And at the time, we went through the details of what the standard is about, looking at the 12 benchmarks in the 4 steps of TB diagnostic cascade. And the 4 steps actually include identifying presumptive TB cases, accessing testing, being tested, and then receiving a diagnosis. And of course, countries are required, therefore, to monitor and improve the ultimate contribution of the administration of this standard to identification of TB cases, treatment initiation, and then improving TB treatment outcomes. In today's session, following that initial session, we're going to look at some of the early implementation experiences, challenges, and lessons learned from Uganda and Nigeria, the 2 countries being 2 of the 3 countries that actually did the piloting of this standard. The other country in Africa is South Africa, and we do know that on a rolling basis, additional countries should be coming on board. We will also share some key considerations that countries headed for the adoption of this recommended standard should make prior to, during, and after the administration of the standard. And so to help us with this exciting session, we have 2 presenters. Our first presenter will be David Asimwe from the National TB and Leprosy Program of the Ministry of Health in Uganda. And then we'll have the second presenter, Dr. Omoniyi Amos. That's a difficult one. So Amos is a national professional officer with WHO Nigeria. So colleagues, allow me to hand it over to our presenters, and we'll start with David from Uganda. David, over to you.
Good afternoon in Kampala, good evening and good morning wherever you are. I'm David Asimwe. I work with the National TB and Leprosy Program as a digital adherence coordinator. However, I have a background in diagnosis. I will be sharing with you the implementation of the WHO standards for universal access to rapid TB diagnostics in Uganda, a pilot that we did last year. I'll start with a simple background. The NTB strategy aims to ensure early detection of tuberculosis, but also detect all cases of drug-resistant TB, scaling up introduction of new diagnostics, not forgetting implementing systematic screening for TB, especially among selected high-risk groups. Diagnostic gaps in 2021, as we can all notice that they were a bit low, given the targets. Percentage of people estimated with TB disease who were notified were at 60%. and a percentage of people newly diagnosed with TB who were initially tested with the WHO recommended rapid test as low as 38%. Percentage of people newly diagnosed with pulmonary TB who were bacteriologically confirmed at 63%, and percentage of people diagnosed with bacteriologically confirmed TB who were tested with rifampicin-resistant TB at 70%. And this shows the programmatic standards diagnosis cascade. We had 4 steps where we looked at identifying a presumptive TB. In step 1, accessing testing, step 3, being tested, but also receiving a diagnosis. And each of these steps marked a certain benchmark. As we can see in step 1, we had 2 benchmarks. Step 2, we had 4, up to step 4, making it 12 benchmarks that we had to look at as a country with the support we received from WHO to pilot the standard. The objectives were to improve access and use of WRDs as an initial test for all presumptive TB cases, but also improve access and use of WRDs to investigate presumptive TB patients identified, and increase in bacteriologically confirmed case detection, but also reduce time to diagnosis. As a country, our vision is a Uganda free of TB and leprosy, and we do this through our mission to provide quality, accessible, affordable TB leprosy prevention and care services to all population groups in Uganda. And our mandate is to form policies, resource mobilization, do budgeting, strategic planning, but also setting standards and quality assurance, providing capacity building, monitoring, and evaluation. Uganda is among the 30 high burden TB HIV countries globally, with over 94,000 cases, approximately 249 new TB cases daily. And in Uganda, about 33 Ugandans die daily of TB. That's how the burden is. Yes, WHO reached out to us to implement the standard, and we had to take it on by ensuring that we put some steps in order. We collaborated with WHO to implement the standard. The task was to establish the 2012 baseline on all the 12 benchmarks, and data and workflow for regular reporting by the country from districts to national level, identifying data gaps from the benchmarks and solutions implemented or recommendations for improvement. Implementation gaps identified from the benchmarks and prioritization for 2024, also capture best practices or tools used for addressing the benchmarks to improve access. This was to enable the country to overcome gaps in data collection by identifying workable solutions, documenting best practices for completing the standard. What was done? What did we do? We had to take a number of steps to achieve this, and some of the activities that were conducted included inception meetings with the key stakeholders, including WHO and the different players in the country. We held a workshop to review the available data and development of the data collection tools, especially for data that wasn't available in the data collection tools. And this was to be administered to the facility staff and the districts. We also engaged in training for field data collectors, especially to collect data that wasn't available centrally. and were able to pilot the data collection tools in one of the districts, Wakiso, and use the feedback to inform data collection process. After which we went for data collection and we conducted data analysis, reporting, and dissemination. This is a work plan. You can see that this activity was done from August up to Jan. However, due to the timelines by WHO, we had to squeeze this, and instead of 6 months, we did it in around 5 months. By December, we were done. That analysis were done, and we were able to report. These are some of the results that were achieved from all the 12 benchmarks. We were able to score ourselves, especially by color coding, to see where we are, but also how to improve. For example, benchmark 1, which looked at a number of household contacts of new and relapse cases, bacterially confirmed and notified pulmonary TB, who was screened for TB, and this stood at 84%, benchmark 2 at 69%. And also we had benchmarks where we found ourselves at 0% number of districts. Benchmark number 3, number of districts in which all facilities are of a TB diagnostic algorithm that requires WRD to be used as an initial diagnostic test for individuals. I'll not go through all the benchmarks. I'll share these slides. The last benchmark looked at turnaround time, and as a country, we scored 36%, which put us in red. What are some of the best practices as a country that we've clinged on to ensure that we improve where we were not doing well? The country has over 17 portable mobile digit X-ray and CAD systems and 5 mobile clinics, which are helping us with supporting diagnosis, but also increase coverage of WRDs to over 350 sites and over 3,000 facilities linked to integrated specimen referral system. We also have a lab expert DS used to monitor tools and transmit results to clinicians and patients. We've tried to improve in DST coverage to 74%, PDST for new and repurposed drugs available, and introduce expert MTB for INH and FLQ testing at subnational levels. Identifying gaps specific to the regions and carry out quarterly mentorships to bridge some of these gaps, but also involvement of key players, especially the stakeholders in the regions, to support regional mechanisms. For example, you say the LPHS TB activity is supporting us with the gene expert access collaborative, especially in poorly performing regions, and the CDC supporting the TB click to ensure that the lab and the clinicians are working smoothly to interface the TB burden in the country. Some of the challenges that we faced during this process included the collection of data from available data sources may seem hectic, because at some point you require to ensure data cleaning, because if you don't do this, you may either overscore or underscore on a certain benchmark. But also missing data in the facility registers, for example, the presumptive registers and the treatment registers, we were interfaced with a lot of missing data. But piloting the benchmark helped us to cover some of these gaps, and we were able to interact with the teams and show them the way forward on how to improve on filling up the registers. At a certain point, we were interfaced with poor or even no documentation especially in the OPD registers at all entry points, but also knowledge gap among some health workers hinders us from progressing and achieving the standard. These are some of the recommendations as a country that we feel other countries should take up if they are to implement the standard. Use of electronic data systems and connected solutions, but also to successfully implement the standard should be.
We seem to be losing David. And I think he was at the point of completing his presentation. He has taken us through the journey that they've gone in implementing the standard with support from WHO, but also other partners that are actively supporting TB work in Uganda. I will now hand it over to Dr. Amos Omoini, that name is still difficult for me, to take us through the experience from Nigeria. And when we get back, we will then get to the questions and answers. Please keep your questions coming through the chat so that then we'll deal with them at the end of this session. Dr. Amos, let me hand it over to you.
Thank you, Francis. Good morning, good afternoon, good evening, all over the world, depending on where you are. We just like to share our experience from Nigeria with implementation of the WHO standard. I'm presenting this on behalf of teams that work together, both at the national level, at the zonal level, the state level, to do this. This will be the outline of my presentation. I will introduce, I will get to also talk about the step involved in implementing the standard based on our own experience, and then show some results and lessons learned, and then I'll conclude. So in terms of background information about the country, we are in West Africa. Nigeria is in West Africa with a population of about 231 million. We are made up of 36 plus one state, that's about 37 provinces, and 774 districts, which we call LGA. We have the highest burden of TB in Africa. We have the 6th highest TB burden globally. We are among the 30 ITB burden country. Our incidence rate is about 219 per 100,000 populations, with estimated 790,000 TB cases occurring in 2023. The country in the last 5 years has recorded significant increase in TB notifications, with our TB treatment coverage rate increasing from like 24% and to 70% in 2023 as a result of innovative interventions that we undertook in the country. In Nigeria, we use the WHO rapid diagnostic tool, the molecular one. We use we have the experts across the country. We have the TrueNAT, we have T-Lamp, and we are still buying more this year, a lot of TrueNAT and TB Lamp, which is going to be used in country. Currently we have over 500 experts MTB machines spread across the country, and in 2022, the WHO developed the standard to monitor universal access to rapid TB diagnostic, as we are all aware. And Nigeria experience was one of the experience shared in that standard. And as we know, the standard contains a set of benchmark which help us to monitor access to rapid TB diagnostic tool. And so when I talk about rapid TB diagnostic tool here, I'm talking about expert MTB, TrueNAT, TB Lamp. LF Lamp is not included, and Nigeria was requested to provide information on this benchmark for the year 2022 by WHO, and this is how we go about it. So these are steps where we undertook as a country. So we have country adaptation of the standard as the first step. Then we have internalizing the standard as the second step. Then we develop training materials. Then we train program staff and partners. Then we roll out the standard. Then we collect data, we analyze data, and then we made the report available, which we share with WHO. So I will go through each of the steps one by one. The first step is our country adaptation of the standard. First is to identify a focal person at the NTP, and also some selected members of a team that we support the rollout of this standard in the country. And so that was the first thing that was done. After that was done, then next was to adapt the 12 standard to align with our national guidelines and implementation in the country. That was done so that everybody in Nigeria understood when we are using the standard, they know the terminology we are using, and not using a different terminologies that is different from our own national guideline. And then the standard originally also aligned with our cascade of monitoring TB diagnosis. So it's in line with what we are doing. It's in line with already what we are doing in the country. So it's all aligned with our system. And going forward, also, after we have done that, we develop an Excel-based template that we allow reporting by state, by zone, by facilities, and also which will be summarized for the country. So, like I talk about the cascade for TB diagnosis in our country. So these are the cascade we used before, like identify presumptive TB, sending presumptive TB for test, presumptive TB getting tested, results released, and starting on treatment. These are cascade that we use in country. So it's pretty much aligned with our cascade of diagnosis in the country. So when we sat down to adapt this standard, this is what we adapt, this is how we adapted. For example, under benchmark 1, we added some risk group, which includes undernourished children. We added diabetic, we added IDP, because these are some of the risk group that we are already implementing active case finding in the country. So we added them into the benchmark. Then we changed district to LGA to align with what we are used to in the country. And at the end of the day, this is the adapted standard that we use as a country. Then after we have adapted the standard, changing the terminology to align with our terminology, we now need to internalize, really understand each of the standard. And to do this, we need to have a meeting together. And so we leverage on on the planning meeting. There is quarterly planning meeting between NTBSCP and WHO from zones, from state, where we look at program implementation together. So we leverage on this meeting, and we use one of the sections during this meeting to look at the standard. And while we are looking at it, we are also able to invite our colleague from HQ who join us online and during the section for the standard. And during the section, the objective of that section was to understand the standard one by one, each of us, clarify the issues raised on any of the standards. So if there are issues raised by colleague who will support the data collection on the field, who will support the capacity building, we try to answer, clarify the issues, and we have technical support from WHO HQ on this, who are there virtually. And then at the end of the day, for us to have the same meaning to all the indicator, all the standard in the benchmark in the standard, and then using at the end of the day, we're able to obtain input which we use to finalize the Excel template for data collections. So these are examples of issues raised during the meeting. For example, we have concerns about benchmark 2. This is just showing example on the term regularity of the use of chest-X-ray at the LGA level. So it is not a policy for us to use X-ray as a screening tool in the country, though we use it during outreaches and co. So what does the term regularity mean? So people need to know what it means by regularity. So we agree that together, for example, to say the use of chest-X-ray during weekly or quarterly community campaigns in the LGA can be taken to be regular. So in the LGA where you have this done, that means that LGA already are using chest-X-ray on a regular basis. So these are some of the examples of the issues that we raised, and the clarification were provided. We went through all the standard one by one. And what we did also in the Excel base is that each of the standard has numerator, as denominator, as the source of information, as the remarks, as also sections that will help you to know what to fill. So after we have done, we have internalized, we have understand the standard, everybody's on board. Then the next one is to develop a training material, which we use to train the people that will collect the data at the facility, at the state, and at the national level. So we finalize based on the output from the internalization meeting. We finalize the Excel template for data collection. Then we develop a PowerPoint presentations. And then these PowerPoint presentations was used for orientations of state TB program managers, state QA officers, state DRTB focus person, and partners from the TACCT and FCT. And the training slide that we developed highlight the cascade of TB diagnosis in the country and link each of these benchmarks to the cascade, so it was easier. And then also this slide also describe each of the benchmarks for easy understanding also. So after we have had our training material developed, now it's time to orientate program staff and partners that we help in collecting the data. So one of the things also we do is that we have regular quarterly zonal review meeting. We call it zonal review meeting, during which we collect data for the state, for the zone, for the country. We analyze data. We talk about new innovations in those meetings. So we leverage on one of the quarterly meetings also, so that we don't have to pay, we don't have to look. We just leverage on that meeting and across the 6 zones in the country. And we use that to train all the state program manager, all the state key officer, all the state directly focal persons and partners during that meeting. And then we present that slide, and the facilitator were from the national program, from WHO, from people that were part of the initial process. And then during the training, questions and concerns were adequately addressed, and timeline and methodology agreed upon. Like for myself, I supported the South-South zone during the process. So after we have trained, we have built capacity. Now is to roll out the standard at the state, at the facility, and at the national level. So we roll out the standard and data. We started collecting the data. I think we started around June. We started collecting data, and then from the central level, state level, and in some health facility. And then we use the WHO zonal officer, the state TB program manager, the state key officer, the state MIE focal person to support the collection of this information in the standard. And then the WHO zonal officers and then the national program officers provided some kind of supervisory facility for the state. So we allocate based on the zone, your zone. So you have a set of states where you support, and then you provide mentorship, you provide to their feedback, you respond to their feedback in those states. And then so we have people that support that. And then the laboratory benchmark also was free for some selected facilities. The aim of facility also is to, there are questions that is masked when you look at it at the state level, that you might not be able to really have an idea of what is ongoing in the facility. So we just use some facility to also see what is happening. So we try to use facility where there are WRD, we try to use facility where there are no WRD, so that we be able to know in terms of access, in terms of challenges, what they face. And for the facility we leverage on our routine supervisory visit, and also we provide some fund for people to be able to go to the facility, and to the state also to collect data. So as we are collecting the data, we are sending the data upward to the national level. So we were reviewing the data, and we are providing some feedback as they submit the data to us. So we review and we provide feedback to you, and then any gap identified are addressed. These are some of the feedback that we use. For example, we use color code as a feedback. This is a color code for the submission from Southwest Zone. So you can see we have about 6 states in Southwest Zone. So the green, whenever you see green, it means all the options you have filled it correctly and there is no challenges with it. Whenever you see yellow, it means you still have gaps in that data. And then whenever you see red, it means that there's no data filled. So immediately you receive this feedback. So you already know where your gaps are, and you're already able to go to where the gaps are and address the gap. So this is the aim of the color code. So we also have a feedback form that we fill. This is an example of a feedback form that was filled for a state, one of the states there. Though they have green in some of the area, but there are still some issues which we try to clarify. You can see for this state, for example, on benchmark 2, the number of LJ in the registry is used regularly with or without card for TB screening was put as 1. Is this correct? Is there any LJ where X-ray is used regularly for screening AKTCs? If there, what is the name of the LJ? So we are even asking, what is the name of the LJ? What's the name of the district where this activity is actually ongoing? So we go through one by one, and we provide each feedback for each of the benchmark. So you can see this is an example of a benchmark feedback form that was filled. Then based on that, we're able to finalize from June to December, we're able to finalize on it, and then we're able to have some results. These are some of the results that I'd like to share with you. Some of the results, one of the results that we were able to, as a program, like one of the things we tell people and we get to understand at the beginning of this of the implementation is that the standard is not being used to rate us. It's being used for us to identify where we are, identify where we need to go, what we need to do, identify what we need to improve on. So it's not a rating. We are not comparing Nigeria with other countries. We're not comparing Nigeria with one state with other. We're just where are we and what we need to do. So one of the things we use the standard for, which is one of the results, is to use data to assess our capacity of our national to report on those standards. So for example, where you see the blue, the NTBSCP, our tool can completely report on those standards. Where you see, where you see the green, not blue, where you see the green, we can report on those standards. Where you see the blue, we can report, but we have some limitations. That means there are gaps in our data tool that we need to improve on. And where you see the brown, there is no reporting tool for this benchmark. So the information is only available at the facility level. So which means we need to think of how do we get this information to the state level, to the national level. So one of the things one of the results that came out of this is that we were able to identify area of our reporting tools that needed improvement. And these are a summary of it that I've shown. One of the things also we show, one of the results, the other results are these, was also we were able to have, this is just showing part of the result. For example, we have area where we are doing very well. We have area where we are not doing very well. For example, as a country on benchmark 1, we can see we have 94% our score, which means we are doing very well. But on benchmark 2, we have 7%. So these are areas where we need to improve on. And for example, for the benchmark 2, as a program, as a country, we are already working on that. And because of that, we have received about, we have procured about 400 X-ray that we use, PDS that we use at the FGA level, and when we are going to apply this data, this tool in 2024, the 7% will have changed because we have more additional about 400 LGA using this HSP. So we have area where we are doing very well. We have area where we're not doing very well. We are scoring about 7%. So we have this at the end of the day. These are some of the results. And additional result also is that with the benchmark, we're able to identify varying gaps in the implementations of the WRD at the state level. And this will guide our future placement. For example, in one of the indicator, one of the benchmark, we help you to know if the machine or its capacity is able to cope with the presumptive you are getting, or if the machine is being underutilized, is there in the benchmark. So with this, we know state where we already have area where we already have a lot of benchmark, WRD, and where we need to put some, where we need to take WRD area of gaps. So that's one of the things it does for us. And then we are able to identify best practices like the monitoring of, for example, monitoring of test positivity rates. So you find out some few LGA are doing that, and they are using that to get their community interventions, to get their case finding interventions, and they are getting cases. So our aim is that with this, we scale up these best practices across to all the LGA. So we are also able to uncover that health facility coverage with TB services is also suboptimal, which limit the use of WRD as primary diagnostic tool. Also, one of the things also we also find is that the tool for written reporting TAT for WRD is not available at the state level, and it's not available at the national level. So we will build this into our laboratory information system. This is a gap, and then we also identify area of gaps that need to be updated in our reporting tools. And luckily, we're able to do some updates in December 2023 on some of the tools. So we'll be able to report better on this. So also on the issue of turnaround time, so if you take the report from the state or from the national, it will not give you a real idea. So we find out that by applying it at the facility level, we're able to see that at times turnaround time varies from facility to facility based on availability of WRD in those facilities. What are some of the lessons that we have learned? Some of the lessons we have learned include that capacity to use the standard is available within the program, and so program can roll it out. Understanding the standard is key to complete the benchmark, and some of the standards still needed require collaboration with other programs. So it's not a data that you collect on your for us on our own. So we have to work with our HI program. We have to work with national program to collect some of this data. And also one of the lessons learned is that there are already some best practices which exist in the program, which require to be scaled up. And then also using program staff to fill the standard, enhance ownership, and continue use of the standard. As we talk now, as a program, we are already using it. The national program is already using it, and we are going to use it also for 2024. Though for 2020, the one within 2022 we receive some funding, some support for that. But for now, we don't need. We just leverage on all our program interventions to report on that to do it, because we find the use is useful for us, and we needed that. So in conclusion, we like to say, as a country, the standard has helped us to know where we are as a country in the rollout of WRT. We were able to identify best practices to be shared. We are able to also identify gaps in our systems that need to be corrected. And we are also able to learn some lessons that will be used to guide our future placement of WRD. And with that, I'd like to say thank you for listening, and also thank you to all that contributed to this presentation. Thank you.
Thank you. Thank you very much, Dr. Amos. And David, what an impressive journey that you've shared with us in picking up and implementing the WHO standard on the cascade for rapid diagnostics of TB. You've really taken us through your journey, but also some of the recommendations on how best that tool can be administered, including the feedback loop that really gets you to getting a very critical piece when you do data collection, wanting to be sure that the data that is being collected is actually accurate, so that you can validly determine what your score is. We have shared both for Nigeria and Uganda, and Nigeria, as everyone might know, they have a decentralized system. And again, how they went about handling this, the implementation of the standard, given their system, getting to the state level, to the provincial level, vis-a-vis the centralized system that we have in Uganda. But also, there are issues related to if data is not available at the central level, how then do you get out there? So some of those have really come through very clearly, but we also still have additional questions related that will help colleagues to appreciate this further. Now, welcome back, David, and thank you again for dealing with some of the questions already in the chat, but we will pick some of those and deal with them right away. Also, do not go away. Towards the end, we will have a comment from our LabCoP portfolio lead on what we will be doing to support countries, some countries, in implementing the same standard for those that probably are just at the start or have not yet even started considering the implementation of this standard. Do not forget, for you to improve something, you should be able to measure that something and know where you are. But for you to measure that something, you should be able to use a tool that will predict correctly what your performance in the different areas. And in this case, the benchmarks that we have that are set for the 4 steps in this standard. So let me get to some of the questions that are available right now. And I'll start with those that are very related to the implementation of the standard. And then I will also go to those that are generally speaking to TB program implementation. And the first question related to this, I'll let it go to Amos. Amos, what is the frequency that you guys have recommended for Nigeria? I know that you spoke about administering the tool again in 2024. So how often are you going to be implementing the standard to see from your baseline how you're progressing?
Yeah, thank you. So our plan is to do it yearly. so that we already have the gap. Although there's a way, we have a system that we can also monitor it quarterly, but we want to do it yearly, so that at the end of the year we are able to compare 2022 with 2023 where we are, 2024 where we are. Like I said, some of the gap we identify in 2023 is already being corrected, and so we will see at the end of 2024 we also administer it to see where we are. So we will do it yearly, though we have a system that we can have a kind of roughly know where we are quarterly, but we intend to do it yearly.
Thank you. And David from Uganda, do you have some considerations in terms of the frequency of administering the standard that you're making in Uganda? I know that probably WHO has just told us that we should do this periodically, but the time assignment is not as explicit. So for Uganda, what are some of the considerations for determining the frequency of this, if you've made any this far?
Thank you, Francis. Yeah, in Uganda, we also plan to do it periodically. However, we haven't determined when we should do the next one, especially that, but as a program, we sitting and mobilizing resources to ensure that we do one soon, and try to see if the support that we've tried to give to different facilities and regions are being taken up, and evaluate ourselves where we are. But as a country also, as I mentioned, we've tried to engage different stakeholders that if a program we cannot come up with robust resources to do this countrywide. For example, you said and CDC, they are trying to, in the regions they support, they are trying to do something, especially when it comes to the benchmarks, where the regions are not performing well. They have always supported, and we're very grateful to this achievement. At least as stakeholders, if they come on board, that waivers the burden of the national program. But as a program, we also plan to carry out one.
Okay. Thank you. Thank you very much, David. And again, Amos, I'll start with you. And you spoke to the fact that when you were really rolling out the standard, you had your very systematic approach to this, including really getting your working team together and all but working to understand the tool, so that every team that gets out there would score the tool the same way any other team would do, because there would be that general understanding of how to score the tool. But you also spoke to the data sources. And so just from your Nigeria experience, kindly share with us, who was determining which data sources to use for which data elements for each of the benchmarks? Was it the country team deciding on that, or we had some guidance from WHO on what the data sources should be, and whether those are centrally available or at the facility then would be the next level of your consideration for this question? So who were the guys determining which data sources would then be most appropriate to score which benchmark of the standard?
Okay, so for us, is the country, is the national, is the program, because we already have our source. We have our primary source, secondary source. Like I said, the standard is not new to us. It's not really new, although there are some aspects that are new to us because we're already doing that. So one of the things also we did also to also make it easier, and so that we are also on the same page, is that on the Excel template we also put the source of the information where you are supposed to get the source. So we also, so that we are on the same page. But I mean, we understand the only area where we have challenges is, like, for example, with the benchmark one, the area that has to do with the screening in nutritional clinic, screening in diabetic clinic, and also screening of PLHIV for TB. So because we are not the primary custodians of those data, so for example, the PLHIV is with the HIV/AIDS program, so we have to collaborate with the HIV program. So each state has to collaborate, work with the HIV program to get that data. And at the national level, we have to work with the national program to get that data. So we state also some of those sources. So it's pretty, for example, easier for us because we already know the source and we put the source in the Excel template. And we determine the source ourselves, the national program, based on our system of reporting.
Thank you. Thank you very much. And that would differ from country to country, depending on the information management system that you would have in your country. And I guess it is a similar situation in Uganda. Now, let me get to still David on the question of data collection. I know that some of the data elements were picked at the central level and others were picked at the facility or regional levels. Kindly share with us your experience on how the data at facility level was collected. And this, please, just align it to the fact that did we have only the central teams trained and deployed to go out there to do the data collection, or did we pick the data collectors from all the regions and some facilities so that when it came to deploying data collectors out there for efficiency, probably you would have most people who are coming from a particular location collecting data in that site so that it is not a very high cost activity, but just your experience on the facility level data collection, how it was handled.
Thank you, Francis. Yes, data collection at the facility level, region and district level. Of course, it was collected by the field teams, but we ensure that we develop tools for them, which they were trained on for a full week. And we ensure that we had centrally data collectors that had to lead the activity, but we also trained data collectors at the regional level. For example, we engaged the regional TB and leprosy focal persons to be part of the data collectors. At the district level, we engage the district TB and leprosy supervisors to be part of the data collection. But also, as I mentioned, we collaborated with IPs at different regions, and IPs helped us with some of their staff because the workload was too much and data collectors centrally wouldn't do this work alone. So we engaged at different levels, we engaged different data collectors. And centrally we trained, but regional and facility, when the data collectors went down to the facility, they made sure that they trained the facility level data collectors so that they smoothen the process. Over.
Thank you. Thank you very much, David. Now, I have a question from David, a gentleman called David, not my presenter today. And he's saying his question is for both presenters. And if any of the two countries is implementing expert MTB/XDR, please comment on how you're integrating that testing using those devices versus the centralized culture facilities that you may have in your countries. And so if you're doing the rapid molecular tests out there, how is this being integrated with your centralized testing, if any, for cultures for MTB? I will let either of you just choose and jump in. Amos, do you want to try this?
Okay,
yes.
Yeah. So for us in the country, like for the SDR cartridges, we have it in all the states. So like the culture and DST laboratory, we have like about nine. Functioning now 9. Though we have capacity for like 11. So, but we have 9 now functioning. across the country, and they are like in zones, in regions. But for the SDR cartridges, which is the 10 color, so we ensure that every state has one, at least one, right? And the way we use it is that once you do your GeneXpert MTB RIF test and you are RIF resistant, the sample is moved to that SDR laboratory, SDR lab, which is within the state, so that we are able to know resistant to INH, resistant to injectables, and or to any of those other medicine, including fluoroquinolone. So that is how it is used. Also, if we have a kind of non-converter, for example, we have a patient that during your monitoring at month 2 is still positive, is still smear positive. So they have access to the SDR laboratory. So that's how we are able to use it, right? So that's how we use it. So it's like provide some kind of extra diagnostic capacity within the state, which allow patient management to start within hours, within days. And then the other sample that need to be moved to the culture and DST lab at the zone or at the region is moved. But the initial results from the SDR lab, we're able to initiate our patient on the treatment, and we're able to provide better management for the patient. That is how we use it. And we hope to, we are going to have more of SDR machine that can do SDR tests, and and then get more of those cartridges in country. That's our plan. Thank you.
Great. Thank you very much. And David, there is one specific question that is directed to you, and it stems from the fact that in the Nigeria presentation, there was a clear demonstration of for each of the benchmarks, they went ahead and they wanted to see if data required to respond to those indicators were available in the routine TB program reporting. And then for those that were not available, they have made recommendations to actually modify some of their routine data collection tools to be able to respond to those, so that going forward, it will be quite easy to pick all the data without necessarily deploying teams to go out there. So for Uganda, did you also do the analysis of what level of responses to the 12 benchmarks are available in our reporting tools, and the gaps that are there, and some of the considerations that you may be making to make sure that they are included, so that 5 to 3 years down the road, you may not necessarily need to deploy teams out there?
Yeah, thank you, Francis. Exactly, as we are going through the data collection tools as a country, and given the gaps that we saw, this helped us to really identify the gaps and see where the problem is, especially when it comes to data collection. We were able to make some recommendations which data should be collected at what level. And for example, if you look at benchmark 12, which looks at TAT, we didn't have this in any of the data collection tools. And this kind of work was so hectic for us that we couldn't find this data centrally. But as a country, we're trying to, see how do we start uploading such data, so that in the near future, we don't have, like you said, to send data collection teams, because this seems to be expensive at times. Over. Thank you.
Thank you very much, David. And I will hold it with you. And for just about 30 seconds, if you could also share with us, because I think at some point in some of the best practices that you shared, you indicated that chest X-ray is actually available to presumptive TB cases. And so my colleague from Mozambique is asking whether the chest X-ray is being done for everyone or some population categories, and if some population categories, which ones are those?
Yeah, chest X-ray is not everywhere, and basically we focus on some population groups, especially the high-risk groups, fishmongers, HIV cases. So it is basically targeted populations.
Thank you. Thank you very much, David. Now, let me bring in my colleague, Dr. Collins Otieno, to just give us a sentence or two in about 2 minutes on what we are planning to support additional countries to enroll and implement the standard, and what else you may want to say in this regard. Dr. Collins, if you're in, over to you.
Yeah, thanks, Francis. And thanks to Nigeria and Uganda for such an exciting presentation. So in line with the expanded scope of the LabCoP, we are also planning to adopt this tool for the TB workstream. And as such, we are going to support the rollout and adoption of this standard among LabCoP countries. And before this session, we have already done a survey among 20 countries to find out what kind of data they have in terms of access to WRD and what are the gaps. So that gives us a baseline on where to start from. And we are also going to tap upon the experience of South Africa, Nigeria, and Uganda to be able to help in rolling out this in other countries. Otherwise, thank you so much, Francis.
Thank you. Thank you very much, Collins. And again, that is exciting news that we can also contribute to the rollout of this very important standard to help us ascertain where we are in terms of the WHO recommended rapid diagnostics for TB. But also once we know where we are, then we can do certain things about it to improve for areas that we are not doing well, but also maintain for areas that we're certainly doing well in. Now, I will give it just 30 seconds to each of our presenters to wrap it up. I'll start with Amos. Amos, your closing remarks. And as you make your closing remarks, kindly also tell us what the cost has been to run this pilot for the 4-5 months that you did it.
Okay. Thank you. I want to say it's an exciting moment to be part of this call, and also to implement the WRG, and also to be able to leverage on our system to roll it out. Most of the cost driving has been the getting people to the facility to collect data, to supervise. Those are the sources, or those are the cost funding and are the cost that we incurred. That I might not be able to say specifically, but from my experience, it might vary depending on the size of the country, from $10,000 to like 20, 30. It might not depend on the country, but like for we going forward, we are going to, we might not need additional, cost. We just build into our system, and then we're able to roll it out and collect these informations, because they are part of the things we're already doing, and we already have some support for some lot of supervision and co. And so, but for the initial process, maybe like from between $10,000 and $30,000, depending on the size of the country, depending on the scope, on how you want to do it, that might be a cost. But I can't say specifically how much it costs us. And we have to look at the how much we spend. But like for us, we leverage mainly on a lot of our system. The only cost driver was the supervisions and then the facility collection of data. So thank you for this opportunity, and we look forward to working with you for that. Thank you.
Thank you. Thank you very much, Amos. And I'll learn your other name. The next time we do it, I'll be pronouncing it right. And so let me hand it over to David, just in about 30 seconds. Your closing remarks, please.
Francis, for organizing this call. It has been really informative that we can share our experiences for other countries to pick up this. And thanks to the WHO for the support that they rendered us to carry out this activity, pilot activity. And I'm happy about the efforts that support for other countries to roll out the implementation of the standard. I'm sure this is a great milestone that we will achieve as a continent. Thank you. Over.
Thank you. Thank you very much, David and Amos, again, for really sharing with us your experience. It's very, very important. It's never easy to be the first to give it a go. But again, we're also excited and happy to note that you're also willing to share your experiences, both on our webinars, but also when called upon to support countries that may want to take up the same. Again, guidances from WHO is generally what should by default be taken up. So we encourage all the other countries to begin considering this so that they can, in an objective way, determine the performance of their TB program with regards to rapid diagnostics, and then do certain things to improve them. And with those, again, thank you for being part of this, and be on the lookout for our next session. And from us, ASLM, we wish you the very best of your morning, afternoon, or evening, depending on where you're joining us from. Thank you.